It is my pleasure to welcome Dr. Jamison Spencer again today for a lecture on temporomandibular joint disorders and to explain a little bit more about what clicking is. Dr. Jamison Spencer is the director of the Centers for Sleep Apnea and TMJ in Boise, Idaho, and Salt Lake City, Utah. He has personally treated thousands of patients with sleep apnea and TMJ problems and now focuses on helping dentists help their patients with such problems. He has a lot of credentials, but I will tell you all of them, or some of them anyway. He is the past president of the American Academy of Craniofacial Pain, a diplomat of the American Board of Craniofacial Pain, a diplomat of the American Board of Dental Sleep Medicine, a diplomat of the American Board of Craniofacial Dental Sleep Medicine, and has a master's in craniofacial pain from Tufts University. He taught head and neck anatomy at Boise State University, and he's adjunct faculty at the University of Utah School of Dental Medicine. He's been invited to give lectures on TMD, dental sleep medicine, and head and neck anatomy throughout the US at every major dental meeting, and has also spoken in Canada, Central and South America, the Caribbean, Australia, Europe, and India. He has created Spencer's Study Club, an online education, mentoring, and implementation program to help dentists and their teams help more of their patients with sleep apnea and TMJ disorders. And he is extremely engaging, so I think everybody is going to thoroughly enjoy this.
So everyone, welcome. Everyone who had the opportunity to listen to Dr. Spencer at his last presentation, the comments were incredibly positive, and people were enthusiastic about our next presentation, as I am. What you will find as we go through the evening, that on Dr. Spencer's slides, I don't know how many of them, but on some of them, there will be a QR code that you will be able to scan so that you'll have the ability to register for Dr. Spencer's 6-hour session, Sunday, November 3rd. And once again, anyone who's been privileged to attend one of his sessions walks away a better individual for it. They can feel comfortable that they now know more than they did before and that they could be even better practitioners for their patients. But in addition to that, Dr. Spencer's presentations allow you to have a deeper understanding how you can use your knowledge to grow your practice. And those two items, that means the ability to educate yourself and as a result care for your patients, and the ability to have your practice grow as a result of it, are great. So without any further delay, Dr. Spencer.
Hey, thank you, Asher. Thank you, Lauren. So QR code is there, really big, but it will be on a bunch of my other slides. I hope that many of you on this Zoom right now will consider joining us. One thing that I kind of pride myself on is being practical and giving practical knowledge that you can immediately use in your practice, and I hope that that is the case for us tonight. So the title is
Don't forget that you can put your questions into the question and answer session, and we'll go to it at the end.
Sounds good. Yeah, so you can put all questions in the Q&A, and we'll take some questions at the end. So the title, what's that clicking? So we're going to spend a few moments on this slide here. These are the famous Yoint videos. We call these affectionately. So Dr. Westinson and Eriksson from Sweden, who, if you watch these full videos, they refer to it as the temporomandibular Yoint. So these are widely known as the Yoint videos. And I don't think anything better than this has been done. Terry Tanaka has some great dissection videos too, but these are still awesome. I'm going to stop that one right here in the normal and let these other play for a second. So here's our condyle. Here's the fossa, articular eminence. The disc is fat, skinny, and then fat again. These tissues back here are called the retrodiscal tissues. We'll talk more about that later. But again, here's the disc. And what I'd like to point out first on this normal joint is how big of a space there is between the top of the condyle and the top of the fossa. Look at that huge space and look at how big the disc is. Also, this right there is with the teeth in occlusion or approximating each other anyway. And we have this condyle. If we were to wipe out the soft tissue, you might look at that and say, you know, I think that that condyle is kind of down and forward, but it's not. This is the normal joint. Okay, let's move on to our reducing disc displacement. So here the person puts their teeth together, pop off the disc, and now upon opening, click into place, When the teeth are together, pop out of place. When the patient opens, pop into place. Okay, now I'm going to stop that here once the teeth are about together, about right there. Now here's the top of the condyle, and there's the top of the fossa. Did you notice my pointer even move? Here's the top of the condyle, here's the top of the fossa. Okay, let's go back to the normal joint. Here's the top of the condyle, here is the top of the fossa. All that space, room for our soft tissue. Here, the disc could not be on top of the condyle if it wanted to be. There is no room. So in a reducing disc displacement case, the disc is displaced and then pop reduces with a click. And that's a little bit confusing terminology. We don't use that term much. Reduce usually we think means make less, right? But in this case, reducing is going back to anatomical position. So if I were to break my arm and I went to the ER, they would reduce the fracture. If I was to dislocate my shoulder, they would reduce the dislocation. That means putting it back in place.
Dr. Spencer, I'm just going to interrupt you for a second. I got one chat that said they don't see the slides or the screen. Andreas, I just want to make sure that everything's being shared.
Are all the rest of you seeing it?
Can someone just go into the chat or to the Q&A and let us know?
No, I'm asking you, Asher, do you see it?
I see it.
I see it as well.
Yeah, everyone should be able to see it.
Everyone's seeing it. Yeah, the answers are that everyone's seeing it. Okay.
There you go. So if they're on their phone or something, it may be the view that they're looking at or something like that, but that would be weird. So yeah, go ahead and put in the chat, but that'd be very strange for one person not to see it. Okay, so back to our reducing displacement. That's okay. So again, the patient opens, they reduce with a click. That is the clicking. So to the answer of what is that clicking? That's what the clicking is. Now, sometimes when we treat these patients, we may use splint therapy or something like that in an attempt to hold them right about here, to keep their teeth from approximating so that they don't displace the disc again. Now, does this look familiar? I just kind of made that joint look like this one, didn't I? Now there's space. Now the disc is in the right spot. That is what we often are trying to do when we're treating these folks. Okay, let's move on to this one now. Non-reducing disc displacement. Here the disc is out of place all the time. On this part of the video, they're actually going to push the condyle forward to show that the range of motion can be somewhat normal even though the disc is out of place. So you'll see them really push that condyle forward, even going in front of the articular eminence right there. So a patient could have a non-reducing disc displacement and you may not know. If I stop that back here as teeth are coming into approximation again, stop, whoops. Here, let me let it go all the way back. And Andreas, somebody's got their mic open, so I might have to have you mute people. Stop. All right, so here's the top of the condyle. Here's the top of the fossa. Top of the condyle, top of the fossa. No room. So what's the big difference between a reducing disc displacement and a non-reducing disc displacement? And you could put that in the chat if you wanted. Let's do it. Let me see if I can see your chats. So put in the chat, what is the big difference between a reducing disc displacement and a non-reducing disc displacement? Put into the chat. Oh, maybe I can't see it. Okay, never mind. I can. The chat is only for the panelists, I guess. So the answer is no clicking. So as a person goes from reducing to non-reducing, we go from clicking to not clicking. And that can be rather confusing because one would typically think, oh, well, it's not clicking anymore. That must be good. I have a little podcast called the Airway Sleep and TMD podcast. If you want to check that out, Airway Sleep and TMD podcast. And one of the episodes is called The Opposite is Usually True. And on that episode, I talk about with TMJ problems, very commonly take what you would think intuitively, flip it 180 degrees, and you would be right. For example, let's go through some of those. Which would be worse? A really loud click that you could hear from across the room, or a really soft click that you can barely notice? You just kind of feel it when you palpate. Okay, take what's intuitively obvious and then flip it. The loud click is better. The loud click has good anatomy, pop, and it just is in the wrong spot. The soft click is a disc that's been beat up by popping and clicking for millions of times and is now flattened so it doesn't make as much noise. Okay, let me try another one. Which is worse? The person who just barely opens their mouth and it clicks? I mean, they just barely open, pop. Or the person that goes open, 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 and finally it clicks. So they're yawning and it clicks, but normally, most of the time, it doesn't click. It only really clicks if they open really wide. Okay, take the intuitively obvious, flip it. The worse is the late opening click, because that means they are off the disc all the time, except when they open wide. Okay, now I know probably some of you are being nauseated by these cadaver videos going over and over again, so I'll go ahead and stop these and we'll talk about the degenerative joint disease one. So sometimes the patient with the non-reducing disc displacement blows through this tissue, and then we have a bone-on-bone situation. And that is the crepitus that you feel with your patients. And here's a curious thing. Everyone on here that's been a dentist more than a couple weeks knows that if you palpate and you feel that crunch, 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 you then ask the patient, oh my gosh, you must have a lot of joint problems and stuff and probably can't eat a lot of things that you want to, right? And then the patient says, no, I'm fine. I can eat whatever I want. I don't ever have pain. Weird. Why is that? It's because there's nothing there to hurt anymore. The soft tissue that we were on here, isn't there anymore. So now it's bone burnishing bone, and that doesn't tend to hurt. As I say to my patients all the time, our jaw joints, unlike our knees and our hips, don't bear weight. So you can have pretty screwed up jaw joints and do just fine. Okay, so that now begs a brief discussion of centric relation. I hope you enjoyed that. I wish that I could see the chat so that you guys could plug this in here, but I want to know, so you're just going to have to
in Q&A. If they write in Q&A, you can be
Q&A.
able to try that. Yeah.
More Q&A. I can't. Lauren, whoops. Oh my gosh. What did that just do? Did I just stop sharing? I do not know what happened. I should not have screwed around with that. Okay, let's stop share for a second. All right, that serves me right. I've only done 4 billion Zoom meetings, so probably doing something that I've never done before is a bad idea. So let me go back to my presentation. And now I got to go back into Zoom. And then I got to share again. Okay, my slides back up. All right, so I can't see what you put in chat. Next time we'll enable that. So bottom line, if you graduated dental school after 1987, which I assume a lot of you on this Zoom meeting have or did, this was the definition. Okay, what I was going to ask you to play along with me on was, if I said CR is the, centric relation is the, to tell me what you were taught in school. Is it the blank, 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 blank position? Okay. And I've done this with thousands of other dentists, so I know what you would have said. So even if I limited it to people who graduated after 1987, most of you would have said things like, well, it's the posterior superior position. It's rearmost, uppermost, midmost. It's terminal hinge axis. You would have had a lot of pushing the jaw back type of things. And then a few of you would have said anterior superior. And then I would have said something like, well, anterior superior, but then others said posterior superior, and I'm no anatomist, but those seem like different things to me, anterior and posterior. And indeed, they are different. So even if you graduated after 1987, when the definition was changed to anterior from posterior, as I'll show you in a second, probably in the clinic, you were taught more posterior. The professor in pros probably pushed that jaw backwards, okay? A couple of them may have done bimandibular manipulation and stuff like that to go more anterior superior, but posterior. So I graduated in 98 and guaranteed we weren't taking joints forward, we were going backward. And that's because there's been a few different definitions of CR over the years. So here, that one we just talked about is from 1987, Glossary of Prosthodontic Terms, edition 5, anterior superior position of the condyle with the disc in the right spot. That is the definition. But if we go back a little bit to Glossary of Prosthodontic Terms 3, most retruded. Okay, that's a big difference. Most retruded to anterior superior. And a lot of people will give Pete Dawson and others of his era credit for this change in the definition of centriclation from a retruded to a more actually anatomical position. Going back in time further, most retruded, most posterior, 4, most posterior, 5, midmost, uppermost, most superior, 6, uppermost and rearmost. A combination of 5 and 6 is where you get rearmost, uppermost, midmost. Now, here's the fascinating thing, though. Let's look at number 7, which was from Dr. Ramsford, which is the original definition of centric relation. A clinically determined position of the mandible placing both condyles into their anterior uppermost position. This can be determined in patients without pain or derangement in the TMJ. The oldest definition and the 1987 definition are the same definition. Anterior uppermost and anterior superior is the same, both of them saying the disc needs to be in the right spot. So as you saw before, if we keep going superior, eventually that disc has to squirt out. That's not CR. The disc has to be in place to be centric relation. It's anterior superior with the disc in place. As soon as we go too far superior, out goes the disc. So this is a bit of a problem we have in dentistry, is if I just tonight said, so it's very important to me that the joint is in CR. And we've got, I don't know, like 100 people on. There would have been at least 5 different definitions in your heads out there. Okay. Now, all of you would have thought, oh yeah, great, CR, cool, got it. Yeah, I agree, Jamison, CR, that's important. But we would have been talking completely different positions. How's that work? And here's something else fascinating to me, because I've been showing this video and doing this for a lot of dentists for a lot of years. And just this last year, as in 2024, I started doing something. I have for years, I've asked, and if any of you have been in a lecture with me, you may have seen me do this. I'll ask in a big group, hey, does anybody have a nice loud click? And I'll find someone in the room that has a really loud click, and I'll go and I'll have them click, and then I'll usually have them close down on their front teeth, which limits their teeth coming together. I'll stop them right around here, have them open and close on their front teeth, and their click will go away. And then I'll kind of make a big deal about it, a big fuss about it. And what I started doing this year that I hadn't done before is I've started asking that dental professional, and it's usually a dentist or a hygienist, and I will say, hey, I don't mean to put you on the spot, but just curious, did you just learn that when you open and your jaw clicks, you're going into place, not out of place? So far, ladies and gentlemen, I am batting 1,000. Everyone I've asked that to said, I just learned that right now. That is rather shocking to me and is kind of what gets me up in the morning. It's what gets me on this right now, and not being with my 6 grandkids out in my pool. I'm talking to you because we need to do better, everybody. We need to know this stuff, because if we don't and we ignore it, people end up getting surgery. And that's not a slam on my surgeon friends. Oral surgeons are awesome, but if us general dentists can't help people with TMJ problems, they end up being dumped on our surgeons, and then their tool is surgery. So hopefully we can understand this a little bit better. And these different pieces of plastic are oftentimes not the answer. I could go through this picture here and show you all of the different things that have been used, and every dentist, oh, by the way, I didn't say this. Every one of these appliances was one patient's appliance. So one patient had all of these appliances. They had been given all these appliances by different dentists. One patient. And I can go through each of these appliances and tell you where that person trained, who taught them, and what the theory was behind that piece of plastic. But in virtually every one of these cases, the diagnosis was wrong. And that's what, again, kind of saddens me a little bit, is we want to throw in the magic piece of plastic there without actually having an accurate diagnosis. So it's not always about the plastic. I want you thinking first and understanding what's going on. And then maybe it is about the plastic. I'll actually show you a splint here in just a minute that we would use for a very specific condition. But understanding the diagnosis is the real key. That's what we're going to be talking about in that full day course, is understanding the diagnosis. And then the treatment becomes actually pretty easy once you understand the diagnosis. So now we're going to talk about disc dislocation without reduction. This is the one where the disc is out of place and stays out of place. And the reason I'm going to spend a little bit of time on this is something that you can pick up as a dentist. And if it's missed, the patient will not get better on their own, and they might progress to that degenerative arthritis problem. They might progress to significant pain and dysfunction. They might have a bite change. But if you can catch this early and get them to someone who knows what they're doing, or you become someone who knows what you're doing, we can get this disc back into place. Just this week, it was last Thursday actually, and then the follow-up was today. A young lady flew in from Brazil to see my partner in our Salt Lake City office so that he could get her back on the disc. She had a non-reducing disc displacement bilaterally, actually. One side was worse. He did the procedure I'm about to show you, got her back on the disc on both sides, and then we followed up, and she's still on the disc a few days later and will remain on that disc with some little things that we're doing. So it was a bummer that I couldn't get her treated in Brazil. I tried to work with the dentist down there, but she ended up having to come to us. So I'd like you all to be a little bit more proficient on these things. So here we go. Based on history, or based on history plus MRI. Based on history, we're going to have a maximum opening of 26 millimeters. They're going to deflect typically to the affected side. So deflection, remember, is your jaw going off to one side and staying there, like that. That's deflection. Deviation is your jaw goes off to the side and comes back. Deviate, remember that's got a V in it. Deviation is when you have a reducing disc displacement. Deflection, non-reducing, the disc is stuck. So your jaw will go to the affected side. Usually they'll have a history of, yeah, my jaw's popped and clicked for years. Usually they'll have a history of, yeah, my jaw catches on every once in a while. And then usually they will wake up locked. Okay, that is the classic presentation of a non-reducing disc displacement. How we determine this for sure, I'll show you in just a second, but what could cause this? Well, trauma is a big cause of a non-reducing disc displacement. So someone getting hit in the face, yeah, that could really do it. But the thing that more than likely causes this in most of our patients is micro trauma. And that'd be the micro trauma of clenching and grinding the teeth. Now, if you're with us a few weeks ago, we did a presentation on clenching and grinding the teeth. And I didn't show this patient during that presentation, but I know that you can get a link to watch that webinar and watch that video, and I'll encourage you to do that. But here's a patient that came in to my office for a TMJ problem, pain and dysfunction in the jaw joint. And we took a cone beam CT to look at their jaw joints more specifically. And on that cone beam CT, we saw this tiny little airway that says 0.8 millimeters, 0.8 of a millimeter at the most narrow point. And it's a really long airway. And then here's the shocking part, is this is the pano that was reconstructed from that cone beam CT. Now, most of you look at that and you're like, yeah, that looks like a normal pano to me. But if you have a cone beam CT, you might notice that something is weird on this. Cone beam CTs, at least in my office, we take with the patient's teeth together in occlusion because we want to see that accurate condylar position. This pano looks like a normal pano that would have been taken with a panoramic x-ray machine where they bit on the little stick. Okay, why do we bite on the stick? In a pano is to bring the arches into the focal trough. But that's not what we would do with a cone beam CT. So in other words, this patient, this is their airway with their jaw forward. This is the only person I've ever seen like this, but this person with their teeth in occlusion obstructed their airway. With their teeth in occlusion, had no airway. And when we saw this, we're like, oh my goodness, we sent this guy for a sleep study and found out that he had sleep apnea. The sleep apnea was addressed and his TMJ problem got better. So in the last one, we talked a little bit about this so-called parafunction or protective function. This is what we'll be talking about in November 3rd is sleep apnea, TMJ problems. And is it possible that some of this bruxism we see on a daily basis could be related to sleep apnea? And again, on the last webinar, I made this case for parafunction or protective function, said what might parafunction lead to, and we know it leads to breaking the teeth and the restorations and TMJ problems and muscle pain and trigger points and all sorts of stuff. And then I asked the question, what if it isn't parafunction though? And made a case that it might actually not be parafunction, but might be what I call protective function, which is that some people will clench or grind their teeth or just posture their jaw to try to protect their airway so they don't die. That's what I refer to as protective function. And there's a lot of literature on this. I just grabbed a very recent study just from July of this year that was a meta-analysis looking at the association between obstructive sleep apnea, temporomandibular disorders. And this is kind of interesting. I normally wouldn't read this much on this. I just let you do it. But they took 1,024 articles and 7 met their inclusion criteria and 6 made it for the quantitative analysis. And that should tell you something right there. Is a lot of the data that we have is kind of garbage. And even this term, temporomandibular disorders, what's that, right? If I was an orthopedic surgeon and tonight I was talking to you about knee, okay, a person's got knee, that's about the same as temporomandibular disorders. That is a huge category of problems. And this is why sometimes our literature is kind of tough. Nevertheless, with the few that made the cut, they found that there was indeed a correlation between temporomandibular disorders and obstructive sleep apnea, that people with obstructive sleep apnea had a higher rate of TMD than those without obstructive sleep apnea. So go back and watch that other webinar of parafunction or protective function. I think you'll enjoy it. Bottom line, when in doubt, rule it out. If you think the person might have an airway issue, check that out. And what? So you're saying treating obstructive sleep apnea could help people with TMD? Well, yes. This is another super recent study that showed that obstructive sleep apnea treatment improved TMJ problems. This is something I see in my practice literally every day. We have people that come in with TMJ problems. We notice that they may have sleep apnea. We screen them, send them for sleep studies. They find out that they have sleep apnea. And even when these people are treated with CPAP, their TMJ problem gets better. Let me say that again. Not with an oral appliance, not with a splint, with CPAP, blowing air up their face, and their TMJ problems often get better depending on what their problem is. Okay, so now back to our regularly scheduled programming. So I do encourage you to go back, check out that webinar that we did a few weeks ago, but let's get back to our non-reducing disc displacement. Okay, so we've got our deflection, we've got our limited opening. Let me skip to some MRIs here. So I'm going to make these bigger in just a second. But what we do is we take an MRI with their jaw closed and with their jaw open, and then we're looking for the disc position in closed and open view. So here's our ear hole. Here's a socket, the condyle going out of the socket. Here's an eyeball, brain up there, lateral pterygoid coming away there, teeth down here. So what we're looking at when we see a normal joint, it's actually kind of difficult to visualize the disc. The disc starts here, goes to right there. Okay, kind of hard to see though. On the open view, a little easier to see. So this hourglass shaped tissue here, that is our disc. Okay, that's our disc there. Condyle, articular eminence, disc in between the condyle and the articular eminence. Okay, so that's the normal side. Here's the abnormal side. So see if you can guess where the disc is, where that tissue is. And if you said, well, I think it's that dark thing right there, you are correct. So here is a non-reducing disc displacement. The disc is in front of the condyle. You even see the condyle kind of pushed back in the fossa there. And then upon opening, the disc is pushed out in front of the condyle. Okay, so that is a non-reducing disc displacement. We get MRIs on these patients all the time, even though we are very confident in our diagnosis just from their history, their range of motion being 26, and their deflection. we'll still get an MRI to confirm that that patient is off the disc before we do this procedure that I'm about to show you. So this is what I call a unlocking procedure, and this is how we do it. So it involves an injection into the jaw joint. So if you right now, sorry for the, I don't know if you guys can hear the little kid noises in the background. So I apologize if you can, but got a bunch of grandkids out here having dinner and stuff. So if you palpate right now in front of your ear and open, okay, do that, and you're going to feel your finger fall into a little depression there. That is where we give the shot. It's not brain surgery if you do it correctly. Okay, Asher is laughing at that joke right there. That was a pretty good joke, I think. So it's not brain surgery if you do it correctly. You get it? Could be brain surgery if you did it wrong. I don't want to scare you though. It's really not that scary of an injection. You go right into the capsule. Our goal is to fill that capsule with local anesthetic. That gives us a hydraulic effect to help pop them back on the disc. So here's how we do it. We wipe it off with alcohol or some other material. We spray some cold spray as a topical anesthetic. Then it's a 27 gauge long. You go at least about halfway. Your goal is to hit the back of the condyle. And then we inject an entire carpule of anesthetic into the capsule. That will give them a fullness on that side. When they close down, they'll feel that they can't get their teeth together. They then move their jaw a little bit and will pop back onto the disc. The vast majority of the time, we do not need to manipulate the jaw or anything like that. The injection alone with that hydraulic force will be the thing that gets them back on the disc. Sometimes we do need to lay hands on the jaw joint, but not usually. Typically, the only time that we're having to manipulate it all is if the person's been locked a long time, and then sometimes we will have to use a little extra force. Normally, the shot is all we need to do if we can get these people early. Time is of the essence. The longer the person's been off the disc, the harder it is to get them back on the disc. My world record is about 2 years that the patient was off the disc. We got him back on. My partners, Dr. Keeney in my Boise office, Dr. Mangelson in my Salt Lake office, both of them have had patients locked for greater than 2 years that they have unlocked. Having said that, all of us on a routine basis have people that have only been locked a couple months that we don't get back on the disc. So just because we've had a couple in our whole career that we've gotten back on that have been locked a long time doesn't mean we want to wait. Our goal is to get them back on that disc as fast as we possibly can. And then here's really the secret sauce, is we make a temporary splint to hold them on the disc. If we allow their jaw to go back to their normal occlusion and get their teeth back into place, think of that video again, and they're going to squirt right back off the disc. So if we don't have some sort of temporary splint, we are going to have a problem there. So we make this with a thermocryl. These are thermocryl beads we get from the airway management company, from TAP, the sleep appliance company. Take these thermocryl beads and we make this splint live for the patient after we've done the unlocking procedure, bringing them into a position that keeps them on the disc. Now, what about arthrocentesis? Probably many of you on this Zoom have sent people for arthrocentesis over the years. We flush out the jaw joint. Now, surgeons will tell you that they will get people on the disc readily. Hang on, everybody, just a second. All right, sorry about that. So with arthrocentesis, the surgeon is flushing out the joint. The patient will be usually conscious sedation. And if you talk to an oral surgeon, if there's any on tonight, I doubt there are, but if there are, they will tell you that they almost always get the patient back on the disc. How do we know they get back on the disc? Just because they open wider? No, it's because it clicks. So we know that they are back on the disc because they were off, and now it's popping back on the disc. They will tell you they do that, but then here's the thing. What happens when the patient goes into the recovery room? What happens the next time they put their teeth together? Remember the video? They're back off the disc. So it's really this temporary splint that makes the difference. Here's just a study that showed that doing arthrocentesis that only 10% of the joints became anterior disc displacement with reduction after the treatment. Again, though, if I talk to an oral surgeon and say, hey, when you do an arthrocentesis, are you usually able to get the patient back on the disc? They'll say yes. And again, these guys know their anatomy. These are not the guys that I meet at my lectures that I say, hey, did you know your jaw's clicking into place? And they're like, no, that's news to me. They know how the jaw joint works. The problem is in that recovery period that they're back off the disc. And in my experience, a lot of times the arthrocentesis will be done and the patient then goes directly to physical therapy. And I mean directly, like drives to physical therapy, but they're off the disc before they get to physical therapy. And then usually we're just pushing them farther out of place. So this little temporary splint thing is really the key. All right, if you like taking pictures of slides, I'm going to pause right here for a second and we can take some pictures of this slide. And as a matter of fact, if we want to open it up to some questions right here before I move on to the next topic, that would be fine with me. Plus, I'll find out if you guys are still there. And maybe you're not.
Everyone, feel free to type questions into the Q&A. We will check to see what they are. The one question that someone did ask is, when is your last lecture going to be available? And that should be sent out within the next 24 hours.
Oh, very cool. Thank you. All right, so let me know if any questions have come in, Asher.
When do you distinguish between injecting directly into the capsule versus the muscles of mastication?
So we would go into the capsule if we think that there's a disc out of place. So the muscles of mastication would be if we think there's a trigger point or something like that. Sometimes you'll do the temporal tendon, and that's part of our differential diagnosis. So let's say somebody comes in and they have limited range of motion, and maybe even they deflect a little. Okay, that could also be caused by the muscles not working correctly, so to speak. And then you would ask, did your jaw pop and click? Has it ever popped and clicked? And the patient's like, no. Okay. So right there, without one question, they're like, no, my jaw's never popped and clicked. You'd be like, okay, this doesn't sound like the disc displacement then. And then you might ask them about how this came about. And they're like, well, it's been kind of over time. It seems like my opening's gotten smaller and smaller over time. And now it's really difficult for me to, eat a hamburger. That's not a non-reducing disc displacement. Non-reducing disc displacement is my jaw used to pop and click. It would catch on me every once in a while. I woke up stuck. Okay, that's your history. So sometimes it will be a temporal tendon, and you can do an injection of the temporal tendon. You do that intraorally, and they'll open nice and wide, and they won't have pain anymore. So good question.
How long do you keep a patient in temporary splint therapy?
So they will wear that temporary splint full time for 1 week. They take it out to brush their teeth, and that's it. So they wear that to eat and everything, which usually means soft/liquid diet for that 1 week. And the biggest risk, if you will, is sleeping. So if they wake up the next day stuck again, then we will typically get them back in, redo the procedure, pop them right back on, and then we'll jump to actually giving them a sleep appliance, so to speak, a mandibular advancement device that one would think about of using for snoring or sleep apnea. We'll give them one of those to make darn sure their jaw can't fall back while they sleep. The little lower splint there, if their teeth are together, it's working. If their teeth are apart, usually that's fine because just having your teeth apart brings that condyle down and forward a little bit. But if they lock up while they sleep, we'll then put them in a more, robust appliance that holds their jaw.
How do we locate the podcast you referred to?
So if you Google Airway Sleep and TMD podcast, I think there's a problem with it on Apple Podcasts right now for some weird reason. So go to SoundCloud, and I know it's working on that.
How do you design the temporary splint to keep the condyle on the disc?
Good question. So from those pictures, if I back up, We do the thermoplastic and we put that right on the patient's teeth. And then the key is having them open and close, staying on the disc. Okay, now at this point, how would we know if they're getting off the disc? They'll click. Okay, so I hope that makes sense to everybody. So if they close down, we will literally feel the disc pop out of place. Then they open and okay, now they're back on. And we have to experiment with, all right, how far apart do your teeth need to be? How protruded do you need to be? We can experiment with that until we find the spot that the disc stays in place. That's where we make the temporary splint. So this picture, just made for the picture, shows her about edge to edge, but it would vary patient to patient on where that needs to be.
Do you recommend any PT for TMD?
That's too broad of a question. So we refer people to physical therapy every day for muscle pain, for trigger points sometimes, for neck problems that are either contributing to their jaw pain and or the result of their jaw pain. So we work with physical therapists all the time, but never in this case. So if we think someone has a non-reducing disc displacement, we would never refer them to physical therapy or a chiropractor because they're just going to push them farther out of place. The physical therapists that we work with, and they have the reverse order there. If somebody comes to them for a temporomandibular disorder and they evaluate and go, uh-oh, deflection, 26 millimeters, jaw used to click, now it doesn't, they send them to us before they touch them.
So I'm not sure I understand the next question, but do we always go from reduction to non-reduction, or can it go automatically to non-reduction?
That's a great question, actually. I wonder if I can't. Let me see. Let me go back here. So that's a good question. Gold star question, actually. Go back to my yucky video here. So the question that they're asking is, do people go from here to here? So we always will go from normal to reducing disc displacement to non-reducing disc displacement to degenerative joint disease in that order. However, the question is, does everyone with a reducing disc displacement eventually become non-reducing? Well, here's one dead person that you would say no. Okay, because I asked Dr. Westinson if they sacrificed these people to make these videos, and he assured me that they did not. That is not allowed in Sweden. So these are people who died, and this person had a beautiful reducing disc displacement upon their death. Okay, so you can have, and there's no changes in the condyle, there's no changes in the articular eminence, there's no arthritic changes, everything's perfect. They just had a nice loud click. This person, well, wait a second, James. So everyone, though, with a non-reducing disc displacement will eventually burn through that tissue and have degenerative joint disease, right? Well, this dead person didn't. So you could have a non-reducing disc displacement. Everyone on this call every day sees patients with reducing disc displacements and non-reducing disc displacements, and you don't even know. Okay. The reducing, I would hope you would know, because if you palpate, it's going to be obvious. Non-reducing, every single one of you has people every day of your practice that has a non-reducing disc displacement. And the only telltale sign to you will be that they open in the 40s. Okay. So I hope that answers that question. So no, not everyone progresses, but if you do progress, basically no one goes from normal to non-reducing. The only way that that would ever happen is with significant trauma. Okay. No one goes from normal to degenerative joint disease. Okay, you have to go through this pathway.
Do patients experience a lot of headaches with reducing disc displacement?
It depends on the patient. So most, I would say, I can't give a most on that, because you got to remember too that I'm jaded, so to speak, because of the nature of my practice. So in my practice, do a lot of the people with reducing disc displacements have headache and pain? Yeah. But the people out there that have popping and clicking that don't have pain, they don't see me in the first place. So I can't give you a most, that's for sure. And when I lecture on this too, I'll usually ask the people in the crowd that I pick, do you have any pain, any dysfunction? Is this affecting your quality of life? And I would say most of the time they say, no, it's a little bit bothersome, but really not bugging me that much. Sometimes they will. Sometimes they will say, yeah, I got to be really careful what I eat, and it does really hurt sometimes. Okay, but again, our practice. Let me put that question back a different direction. If somebody had muscle pain, headaches, and they had a reducing disc displacement, would you ignore it? Okay, and let me use an analogy for that. If I went into a physical therapist because I had neck pain, shoulder muscle pain, headache up the side of my head, pain down my arm, and the physical therapist said, "Oh, Jamison, oh my goodness, that sounds terrible. Let's go ahead and examine you here. Like, go ahead and take your shirt off and let's look at your shoulder and your muscles that are hurting so bad." And I take my shirt off really carefully, and the physical therapist immediately notices that my shoulder's dislocated. What do you think the first thing they're going to do is? Probably relocate my shoulder, right? They're probably not just going to say, "Well, why don't you take some Advil? Why don't you try hot compresses? Why don't you just wear looser shirts?" That'd be the equivalent of chew a soft diet. But we do that stuff all the time. So we'll have someone with a dislocated joint and ignore it. Well, yeah, just stop chewing gum. Just soft diet. Take some Advil and ignore the dislocation. And that, again, kind of bothers me because that's kind of stupid when I use an analogy like that, isn't it? But frankly, most of us, for most of you on the call right now, this will be the most TMD education you've gotten in your career, perhaps. And I don't say that, I say that to not be derogatory towards our dental school education, but we just, there's no time to go over this stuff. And even if they do go over it in dental school, you don't have any clinical experience with it. So it's really, really difficult for us to be experts on everything. And this joint is the forgotten joint. Medicine doesn't own it. Dentistry doesn't seem to own it. Even being paid through insurance and stuff, it's not covered by dental, and usually it's not covered by medical. If it ever is covered, it's on the medical side. So that can be kind of frustrating. Okay, should we move on, Asher?
This is a good segue into the next question. What is wrong with treating the disc out of place? We know the joint has excellent healing potential and pseudodisc formation occurs. MRI studies of the normal population show about 30% of the population has a disc displacement with no other symptoms.
Sure. So if 30% of the population had a dislocated shoulder, we should probably just ignore it. So a lot of that stuff, and I don't mean to be flippant on that, but I understand that I am being a little flippant. And it's because there's not been a solution, so we have no problem. If dentistry doesn't have a solution, we ignore the problem. And yes, there can be a pseudodisc creation, which is that retrodiscal tissue can change and callus, so to speak. And I'm going to give you something at the very end. So whoever asked that question, hold on till the end, because I'm going to show you how you can make that even more predictable. But right now, most of the time, most of the people treating this, you would have no way to predict who's going to go down that positive road of a pseudodisc formation and who's going to break down. So if that was your 18-year-old daughter with the disc out of place, what would you do? As for me, I try to get it back on the disc. Okay, I move on because that is a good segue to this. All right, so now we're going to talk about retrodiscitis, which is an inflammation of this retrodiscal tissue. And I kind of titled this one of the most common misunderstood, ignored TMJ disorders. And it's once again because we don't really know what to do, so we just kind of ignore it. And remember on our disc displacement, so when this disc is anteriorly displaced, the condyle is on the retrodiscal tissue. This tissue here was never designed to have pressure put on it. It is chock full of blood vessels and nerves. And when there is pressure on it, it can get stronger. So if I do this with my hands, and maybe I do it just the right amount each day, I'll get calluses. Okay, if you're out working in the garden all summer without gloves on, maybe you built up some calluses. Okay, on the other hand, if I just do this over and over again and keep doing this for a day or two, my hands are going to be bloody. So the reaction has to do with force and frequency and duration and all sorts of complicated stuff for us to know what this is going to do. But the bottom line is the disc was designed to have that pressure, and it has no blood vessels, no nerves, can take all that pressure, no problem. Retrodiscal tissue, definitely not. So what a retrodiscitis is again, it's this tissue here that condyle's on. It's this tissue here that condyle's on right now. It's this tissue back here that the condyle could get pushed into and hit. It's that tissue getting inflamed. All right, diagnosis, history of trauma is usually the thing. And this could be trauma of getting hit in the face, or it could be trauma of having their mouth open for an hour in your office. Continuous joint pain, palpation hurts when you push on it. Their range of motion will not necessarily be reduced. So they can still open wide, but they'll do it very slowly and gingerly. They'll have an acute malocclusion on the injured side. So if I have a swollen right joint, think of the swelling there. My condyle can't seat all the way, so the teeth will be apart. The malocclusion is open bite on the affected side. That can be confusing because normally you're looking for hyperocclusion, and this is no occlusion. When they try to get their teeth together, that pushes on that swelling and hurts even worse. If we put something between their teeth, though, like a pen or a tongue depressor, and they bite on it, that won't hurt because the condyle can't seat all the way. What do we do? So anti-inflammatories, physical therapy, and I'll go over these. So the anti-inflammatories I usually use, just simple ibuprofen. You can put them on a Medrol dose pack if you want. I only do that if they've had a positive experience with steroids in the past. We will refer these people to physical therapy, or at least we have in the past. And this is called iontophoresis, where we push a steroid across the joint. This is called phonophoresis, where you do it with ultrasound. However, we are doing this differently now, so stay tuned. Splint therapy for this, we need to be careful because this is a acute swelling and their bite is off, so their occlusion's off. So we have to be a little careful with our splint, and really, ideally, we would use a splint that would self-adjust, and that's what this thing is. So hopefully most of you are familiar with the Aqualizer. If you're not, this thing's amazing. So it's two lakes connected by a river. These little pads go between your posterior teeth. The river part goes between your lips and your gums in the front. So in front facial to your front teeth, the pads go in the back teeth. Your posterior occlusion is perfectly even with an Aqualizer between your teeth. It can't be otherwise. You can find that aqualizer.com is their website. Great company, great device. We use this literally every day in our practice. One of those things that I almost couldn't practice without. And the patient will wear that for 4 to 7 nights with the Advil. Usually that swelling will then go down and they take the Aqualizer out and tap, they're back to normal. After this is resolved, we may put them through splint therapy depending on what caused it in the first place. If their retrodiscitis was caused by getting hit in the chin playing basketball, then clearly we don't need any type of other treatment. We just need to, educate them on being a little bit better playing basketball so they can get hit in the face. All right, here's another one of those slides to take a picture of. And then I got a little bonus content for you here, and then we're done. So this is our retrodiscitis recap: pain in around the jaw joint, posterior open bite on the affected side. It hurts to try to bite together. It does not hurt to bite if you put something between their back teeth, like a tongue depressor in your office, like a pen, if it's over Zoom or over the phone. Anti-inflammatories and Aqualizer is the treatment. I've diagnosed this from thousands of miles away. One of the most egregious stories about this is a family found me somehow. They were in Toronto, and their daughter was going in the next week to have open joint surgery at Sick Children's Hospital in Toronto. And this young lady had a retrodiscitis. That's it. So with very simple treatment, she was better in a week. And she was going in to have open joint surgery. Very sad to me. Okay, so that's our retrodiscitis. I'll hold questions now. I'm just going to give you a little bonus content here, and then we will kind of end, and I will answer any questions. So I put stay tuned for how this is changing, because we are now doing something, and this, you got to come to our course in November to kind of get all the information on this, but we are using now platelet-rich fibrin injections into the jaw joint to massively change how we are treating people here. And whoever asked the question about the pseudodisc, nowadays we treat people, forever we've treated people off the disc because we can't get them back on the disc. Somebody comes in and they've got that history I gave you but it was, my jaws popped and clicked when I was a teenager. It used to catch on me when I was in college, and I've been squashing Subway sandwiches for the past 15 years. Well, that's not someone I'm getting back on the disc. So historically, we would do a night guard, we do various spacers between their teeth and hope like crazy that that helped them avoid getting worse. Nowadays, we're actually trying to reverse their problem, at least with arthritic changes and stuff like that. So some of you are familiar with platelet-rich fibrin, and there's many, many uses for this in dentistry. Just in a nutshell, and to do this very quickly, again, I'll go over this more in November, but we grab the person's blood, we spin it in a centrifuge, we concentrate the platelets and the fibrin, inject that back into them. And I'll just quickly go through some before and afters here. So what you'll see over and over again is a cortical plate that's kind of broken down, and then it back. So this is after 3 injections spaced 1 month apart, and then the final photo or the final cone beam CT was taken 1 month after the 3rd injection. So injection into the jaw joint of this PRF taken from the patient, nothing else, no exosome, stem cells, stuff like that, PRF into the joint, and that's the result. Pretty cool. This one had a subchondral cyst, little breakdown here, gone, cyst, cortical plate back. Another one, cortical plate kind of beat up, getting better. Here's from the sagittal view. So here we have cortical plate pretty much missing, all back. Again, missing, back, missing, back. This is an interesting case. This is my friend Dr. Briesmeister from Virginia. This is an MRI. Here you see the disc. Here's the back part of the disc, the front part of the disc, and kind of a hole in the disc. So back part of the disc, front part of the disc, hole in the disc. He thought the patient had a non-reducing disc displacement. That's why I got the MRI. Found out through the MRI, the disc wasn't out of place. It was in place, but it did have a hole in it. Patient had pain. He treated her with PRF, did 2 treatments, got her back in for a follow-up MRI, and the disc was filled in. The radiologist talked about an incomplete tear in the meniscus on the pre-treatment MRI, and after those 2 sessions of PRF, the partial thickness tearing, as was seen on previous MRI, likely representing interval granulation tissue scar, suggesting of ongoing healing. If you would have told me 2 years ago that that was possible, I would have thought you were crazy. If you would have told me 2 years ago or 3 years ago that we could get that bone to come back, I would have been very skeptical. But this is something now we are doing in both my Boise and Salt Lake practice, literally every day. My partner in my Salt Lake practice has now done more joints than anyone on planet Earth with PRF, and the results are amazing. And I'll finish with this one. So this woman has a practice in the Seattle area. Here's a coronal shot of a condyle from a patient that came in with just kind of relatively typical TMJ pain and dysfunction. Tanya treated her with basically traditional splint therapy, if you will, did traditional things with her. Patient got significantly better. She weaned her off of the splint she was wearing during the day, continued to have her wear a night guard. And then about 6 months after that treatment was basically completed, the patient had pain again. Came back into Tanya, said, hey, this is hurting again. Tanya took a follow-up cone beam and found this. Tremendous breakdown of the condyle, that same condyle. Most of the time, if you saw something like this, you would think, okay, this person's got to go have open joint surgery. This is bad, bad, bad news. Tanya thought, well, can't hurt. Let's go ahead and do some PRF with this patient. She did 3 treatments over 3 months and then took a cone beam CT after that 3rd treatment a month later, and this had occurred. To put that all on one slide, there you go. Breakdown of a dramatic nature and filling in with 3 simple shots into the jaw joint, taking the stuff out of the patient's arm and putting it back into them. So that's that. If you want to learn more about that and other stuff, take a picture of that QR code. Join us Sunday, November 3rd. I'll go ahead and take a few questions.
So I have 2. One is any contraindications to using this therapy during orthodontic treatment? Should we resolve before?
I'm not sure what treatment they're talking about.
They were talking about removing the disc back into these questions came up when you were moving the disc
Oh,
back into place, and making
cool.
the appliance.
Yeah, so ideally, you would for sure get them back on the disc prior to finalizing orthodontics. Because if we, here, let me go back. Let's go back to the slide we showed 400 times. Okay, so let me stop all these guys. All right, so here's our disc displacement, and we try to hold that person with splint therapy or whatever right there. Okay, what did I just do? So if that is currently where the person's teeth are in occlusion, habitual occlusion, and then we try to keep them on the disc, and it makes sense restoratively to hold them right around here. What changed? So that right there, that person would have a posterior open bite. Now, I've seen lots of cases where that person goes from class 2 molar to class 1 molar in that situation. And all of a sudden, a very complicated orthodontic case now looks a lot easier because the joint, this mandible, is in a better position. So ideally, you would get the joint in an ideal position and then finish where the teeth are, if you can. Okay, if you can. The way we treat and the way I teach is you could have someone that you treat that has been off the disc, you get them back on the disc, and you don't need to change their bite. So we almost never have to do what we call phase 2 treatments. We don't do a lot of orthodontics afterwards. We don't do crowning the teeth. Again, to pitch the November course, come in November, we can talk more about that. But if you are already doing a full mouth reconstruction or orthodontics, then yes, if you're treating my kid, we're going to try to get their joint as ideal as possible before we change all their teeth.
What do you find is the most efficient source of relief/treatment for patients who have TMJ pain/discomfort that is not sleep apnea related?
That would depend on their diagnosis. So it would be diagnosis specific is the only way I can answer that question.
Are the PRF injections well tolerated by patients, and are they painful?
So yes, they're well tolerated. No, they're not painful. And why that is because it's their blood, and the pH is neutral. So unlike an anesthetic injection that is acidic, and so it stings, burns, the PRF injection you don't really feel. So they will do the topical just like we always do, which in the jaw joint, that's the cold spray, and then just good injection technique, and you're in the joint, and they really don't notice a difference, or they don't barely notice. Once you're kind of getting towards the end, there may be a little fullness, but not painful. People tolerate it super, super well.
Great. So it's 8:04 already, and I want to thank you for spending more than an hour with us. Everyone who was here participating, and there are still 109 on board, I'm sure that you found yourselves quite impressed with the quality of this lecture, and equally impressed with the quality of the initial lecture. Please take advantage of the QR code on the screen. I just want to announce that we're going to have a flash sale so that those people who would like to participate, if you participate in the next 24 hours, there will be a significant reduction on the fee of $125. That is significant in my mind. And anybody who has had the opportunity to spend more than an hour with Dr. Jamison walks away with a notebook and a head filled with information, so much so that they feel the need to come back and hear him once again. So all of you have a great evening, and I really hope that I see some of you on November 3rd, Sunday. So please scan the codes. We'll leave it on just for a minute or so, and come on down. Thank you again, Dr. Jamison, and please say goodnight to the grandchildren.
Thank you very much. Thanks, everybody, and hope to see you November 3rd.